Imagine sitting down at a restaurant, having a nice meal, and then asking for the check.
Always the best part, right?
Oh, yeah. But instead of seeing a line item for, a steak and a glass of wine, you get this 10-page receipt.
Oh, wow. 10 pages.
Yeah. You are charged separately for the waiter's footsteps, the depreciation of the salt shaker, a fee for the electricity the oven used, and get this, a consulting charge from the sous chef you never even met.
You would be absolutely furious.
You'd probably walk out. And yet, when you interact with the healthcare system, that is exactly the kind of bill you expect to get. You go into the hospital for a procedure, and you receive this massive, scattered pile of individual receipts.
Right, a charge for a needle here, a separate bill for a scan over there.
Exactly. It's a mountain of a la carte items that makes absolutely zero logical sense to the person who just went through the medical event.
Well, I mean, it's incredibly fragmented,
Mm-hmm.
and it's a symptom of, well, a much deeper structural problem.
Which we're getting into today.
Right, because what you're describing is what the healthcare industry calls fee-for-service.
Yeah.
It is a system built to document and bill for every single isolated interaction, like every tiny moving part.
But it misses the actual patient.
It really does. It completely misses the actual story of your health.
Yeah.
It tracks the transactions, but it loses the patient entirely.
And fixing that massive disconnect is exactly what we're decoding today. Welcome to the deep dive.
Glad to be here.
We have our hands on a fascinating policy framework document today. It's essentially a set of architectural schematics for the healthcare system.
A literal blueprint.
Literally. It's called the Episode Blueprint, edition 1.0, published in 2026 by Dr. Frank G. Opelka. And the mission of this deep dive is to explore how this blueprint attempts to completely rewire how healthcare is delivered, how it's tracked, and financially rewarded.
Yeah, it's basically a guide to move physicians away from that scattered pile of receipts and towards something they call episodes of care.
Okay, let's unpack this. What exactly does a care episode look like mechanically? I mean, how does it actually replace the pile of receipts?
So to understand the mechanics of an episode, we really have to look at the foundational flaw of the old way, which is built entirely around what they call an encounter.
An encounter, like a single visit.
Exactly. An encounter is just a single claim in the billing system. It's that one 15-minute visit to the doctor or maybe just that one specific blood test.
Right.
When a hospital tracks its success or even its revenue based on encounters, they are missing the forest for the trees. An episode, according to this policy paper, is a completely unified package.
Like a bundled deal.
Yes, it consolidates all those fee-for-service things. It bundles together the physician services, the labs, the imaging, the specialty consultants, medications, procedures, and, this is crucial, all the pre- and post-treatment services.
Oh, wow. So from start to finish.
Right. It tracks the entire clinical story from the moment a condition starts acting up all the way to its resolution.
So under fee-for-service, it's like trying to build a house by buying every single nail, every plank of wood, and every hinge a la carte, completely devoid of a master plan.
Yeah, that's exactly what it's like.
You just have a pile of materials and you just kind of hope it resembles a house at the end. But Dr. Opelka's blueprint provides the actual architectural schematic for a complete start-to-finish care package.
That analogy perfectly captures the financial side. But let's push that further into the medical side because the blueprint establishes a golden rule that changes how a doctor actually approaches the patient.
Okay, what's the rule?
The rule is start with the condition, not the procedure.
That with the condition.
Yeah. This is where the framework moves from just bundling payments to creating what it calls a condition arc. Take a knee replacement, for example.
Sure.
Under the old system, the knee replacement is an isolated mechanical event. You pay for the surgery. But under the blueprint, that surgery is just one procedure that lives inside the broader long-term condition of osteoarthritis.
Ah, I see.
The blueprint insists that tracking the whole arc of the condition is the only way to separate merely counting procedures from, actually improving a patient's life.
Okay, I have to pause you there, though, because whenever I hear the word bundling or packaging in a corporate or institutional setting, my alarm bells immediately go off.
I get that.
Right. If the whole point of this blueprint is to bundle procedures into these highly efficient, neat little financial packages, isn't there a huge risk that health systems will just turn into assembly lines, like a Jiffy Lube for joints?
A jiffy lube for joints, I like that.
Because if they get incredibly efficient at the bundle, the financial incentive would be to just start doing more knee replacements, right?
That is precisely the trap that previous healthcare reforms fell into.
Hmm.
And honestly, it's exactly what this blueprint is engineered to avoid. The mechanism here relies on the denominator.
The denominator,
Right.
meaning the total number of patients.
Exactly. By forcing the hospital to look at the broader condition arc, meaning all the patients who have osteoarthritis, not just the ones who get surgery, the first question a health system has to ask changes entirely.
So it isn't how efficiently can we do a knee replacement?
Right. The first question becomes, at what rate does osteoarthritis actually require a knee replacement in the first place?
Oh, wow. So you have a total pool of patients, and you're tracking how many of them actually get escalated to the operating room.
Yes. What's fascinating here is that the blueprint recognizes that the biggest lever for improving value in healthcare is often the surgery that is avoided entirely.
Wait, really? The avoided surgery?
Absolutely. If a hospital can manage a patient's osteoarthritis with physical therapy and, say, weight management and avoid the risks of invasive surgery altogether, that is a massive win.
But under the old system.
Under the old system, if you only track the encounter of a surgery, that avoided surgery is totally invisible. It generates no data, no bill, and no reward. The condition arc makes the avoided surgery visible.
Okay, so it's not just about building the house efficiently. It's asking the structural engineer if we even needed to build a house on this lot to begin with.
Precisely.
That makes a ton of sense conceptually. But let's get into the reality of how this is actually enforced. Once you've bundled all these services into a neat package across major service lines.
Right, like cardiac care or musculoskeletal issues, behavioral health, digestive conditions, and more.
Yeah, exactly. Across all those service lines, how does a health system actually prove that the bundle was any good? I mean, how do they measure success in a way that isn't just counting dollars?
Well, that leads us to the core engine of the framework. The blueprint takes these broad clinical areas and creates specific use cases. These are clinical focus areas to inform, improve, track, and reward care.
Okay, use cases.
And to evaluate these use cases, the blueprint demands that every single care episode answers 3 fundamental value questions. They call them the 3 proofs of value.
All right, let's hear the 3 proofs.
The first is proof of service. This is essentially the financial and operational efficiency metric. It asks, was the care efficient?
So that's tracking the money.
Yeah, it measures the total spend, the unit cost of the items used, and the site of service. Like, could this have been done safely in an outpatient center instead of a highly expensive inpatient hospital bed?
Got it. What's the second one?
The second is proof of safety. Was the care free of avoidable harm? This tracks the immediate negative outcomes.
Like readmissions.
Exactly. Readmissions to the hospital within 30 days, surgical site infections, or physical defects resulting from the procedure.
Efficiency and safety, I mean, those seem pretty standard. Honestly, I would hope hospitals are already tracking if they are bankrupting people and giving them infections.
Certainly do. And those are mostly visible in the existing data. But the third proof is where the entire paradigm shifts. And it is the central obsession of this blueprint.
Okay, lay it on me.
The third is proof of benefit. Did the patient actually get better? We're talking about tangible relief of pain, restored physical function, remission of a chronic disease, and just overall quality of life.
But wait, proof of benefit has to be incredibly subjective, doesn't it? How do you measure I can walk up my stairs without wincing anymore in a billing system?
You've hit on the biggest challenge in modern medicine right there. Proof of benefit is the hardest thing to measure, and it is almost completely invisible in traditional claims data.
Because it's not a transaction.
Right. Medical billing relies on what are called CPT codes, current procedural terminology. It's essentially the vocabulary of healthcare finance.
Okay.
There is a CPT code for cutting a patient open, and there's a CPT code for stitching them up. But there is absolutely no CPT code for the patient played catch with their kid without back pain 6 months later.
Which is crazy because that's the whole point.
Exactly. Proof of benefit is the entire point of the medical profession. The blueprint argues that a health system that only reports on its cost and its infection rates has really only answered one of the 3 critical questions.
Okay, human nature tells me there is a massive loophole here, though.
Let's hear it.
If proof of benefit is so incredibly hard to track and proof of service like slashing costs is really easy to track on a spreadsheet, Won't health system administrators just focus on the easy stuff?
Ah, the path of least resistance.
Right. They could just cut the budget, look amazing on the proof of service metric, and just ignore the fuzzy, hard to measure patient benefit side. How does the blueprint actually stop a hospital from cheating the system like that?
It stops them using a structural mechanism called the seven-part anatomy. Every single bundled care episode must be constructed using this exact seven-part schematic.
7 parts. Okay, what are they?
Well, I won't just list them all out randomly because the way they interact is the key. It starts with the strategic intent and the cohort, meaning exactly which specific group of patients are we tracking.
Makes sense.
Then it defines the acuity, which is how sick or complex those patients are.
Right, because you can't compare the outcomes of a healthy 30-year-old with a frail 80-year-old.
Precisely. Then comes the cost architecture, which is the financial map of the bundle. But here's the mechanism that prevents the cheating you mentioned.
How does it work?
The blueprint explicitly ties the cost architecture directly to two other parts: near-term quality and enriched longitudinal quality.
Enriched longitudinal quality. That sounds like a corporate mouthful. What does that actually mean for the patient?
It means long-term accountability.
Hmm.
Longitudinal refers to tracking the patient over a long period of time, well after the initial encounter is over.
Oh, I see.
By legally or contractually demanding that longitudinal quality is reported right alongside the cost architecture, a hospital cannot just slash its budget and walk away.
Because it'll show up in the long-term data.
Yes. If they cut corners on a surgery, the longitudinal quality metrics, like a mandatory functional assessment 6 months later, will absolutely tank. The financial reward for the bundle is contingent on the patient reaching their functional goals months down the line. It creates a closed feedback loop. And rounding out the 7 parts is the clinical anchor, the baseline medical guidelines.
I see. It's like putting a strict structural warranty on that house we built. The contractor doesn't just get their final payout for slapping the roof on quickly.
No, their payment is held in escrow, so to speak.
Right. Held until they prove the roof doesn't leak during a rainstorm a year later.
That is exactly how the mechanism functions. It forces a long-term view.
Okay. To really grasp how this 7-part anatomy changes behavior on the ground, we should probably look at how it applies to real medical situations. Let's talk about a notoriously tricky area of healthcare: our backs.
Oh, absolutely. The blueprint spends a lot of time diving into lumbar and sacral spine surgery. It's use case O5, actually.
Spine surgery seems like the perfect illustration of the tension between simply managing costs and determining actual appropriateness.
It really is. The blueprint highlights a massive ongoing issue in American healthcare, which is the dramatic overuse of spinal fusions compared to simple decompression surgeries for people with lower back pain.
Let's make sure we have the medical context clear for you listening. Decompression surgery is essentially going in and shaving away a bit of bone or tissue to relieve the pressure on a pinched nerve, right?
That's correct. It's relatively straightforward.
Whereas a fusion is a major undertaking. It's literally joining 2 or more vertebrae together with metal screws and rods to stop them from moving entirely.
Yeah, it's a massive difference. For many common conditions like lumbar spinal stenosis, the foundational medical guidelines, which the blueprint calls the clinical anchor, often recommend starting with just the decompression.
Because it solves the nerve pain.
Right. But over the last 2 decades, the rates of spinal fusion have just skyrocketed. And here's the problem. Fusions are vastly more expensive, they carry significantly higher surgical risks for the patient, and they require months of grueling recovery time compared to a decompression.
So going back to the car metaphor, it's like taking your vehicle to a mechanic because you hear a slight rattle. The clinical anchor says, just tighten that one loose bolt.
Right.
But instead, the mechanic insists on completely removing and rebuilding the entire engine block. I mean, sure, the rattle is technically gone, but the intervention was incredibly invasive, it cost a fortune, and it fundamentally wasn't necessary.
Yes, and under the old fee-for-service model, the mechanic gets paid a massive premium for rebuilding the engine, with no one questioning if the bolt just needed tightening.
That's wild. So how does the blueprint fix it?
Here's how the feedback loop works. It uses the cohort denominator we talked about earlier, all the patients presenting with the condition of low back pain. Then it tracks the rate at which those specific patients are receiving full spinal fusions.
Ah, so it flags outliers.
Exactly. When the data flags a specific hospital, or even a specific surgeon whose fusion rates wildly exceed regional or national benchmarks, the system intervenes.
What happens then?
It triggers mandatory peer-to-peer reviews. Other surgeons step in and basically say, show us the clinical evidence that this highly invasive option was actually appropriate for these specific patients.
That is incredibly powerful. It uses the macro data to actively police the appropriateness of the microcare. It's not just accountants arguing over the cost of the titanium screws.
No, it's doctors holding other doctors accountable for the medical necessity of the procedure itself.
That's a huge shift.
And we could look at this from the exact opposite direction, too, where the surgery itself isn't the problem, but rather the ultimate driver of that elusive proof of benefit. The blueprint showcases bariatric surgery as the gold standard for this. Use case 11.
Bariatric surgery, like a gastric bypass or a sleeve gastrectomy for severe obesity. How does the blueprint treat that differently?
Well, in the traditional fragmented world, a bariatric surgery is just a high-cost surgical event. The insurance company looks at it as a massive expense on a Tuesday.
Just a huge bill.
Right. But the blueprint's longitudinal quality metric radically reframes it. It doesn't just track whether the stomach was reduced safely without infection. It tracks the patient's journey for years.
So tracking the long-term benefit.
Yes.
Yeah.
Did they hit their target weight goal? Were they able to completely stop taking their expensive daily medications? Did they achieve total remission of severe comorbidities like type 2 diabetes and hypertension?
Okay, here's where it gets really interesting. Because it forces the financial system to view the surgery not as a sunk cost, but as an investment.
Exactly.
If you cure the diabetes, the healthcare system saves hundreds of thousands of dollars over the next 2 decades. The proof of benefit is undeniably clear.
It's a complete win-win.
But I have to imagine that tracking this financial and medical data isn't always clean. There was a really fascinating quirk mentioned in the blueprint regarding upper endoscopy's use case 09 that stood out to me.
Well, the endoscopy quirk, yeah.
It really highlights how absurdly messy billing data can be.
You're referring to the coding caveat between diagnostic and therapeutic procedures. This is a crucial point about the limits of raw data.
Yes, so get this. Imagine you go in for a purely diagnostic upper endoscopy. The doctor is just putting a camera down to look around and see if anything is wrong. Because it's preventative and diagnostic, insurance plans often waive the cost sharing, meaning the patient doesn't pay a copay.
Right. It's basically a free screening for the patient.
But if the doctor is looking around and happens to spot a polyp, they will naturally remove it right then and there. The moment they snip that polyp, the procedure suddenly changes its classification from diagnostic to therapeutic.
Instantaneously.
The fundamental intent of the procedure changes midstream based on a spontaneous finding. And because of complex payer rules, that sudden change completely distorts the cost data.
Yep. Suddenly, cost sharing might apply, facility fees change, and the billing looks completely different.
It creates chaos on the spreadsheet.
It really does. And it perfectly illustrates why the blueprint warns administrators against taking claims data at face value. If you define a bundle of care strictly by the financial data on paper, it's just a hypothesis.
You have to look at what actually happened.
Right. You have to validate it against how the messy reality of medicine actually happens in the room. If a health system judges a doctor's efficiency purely on that suddenly distorted endoscopy cost data,
The algorithm might punish them.
exactly. An algorithm might automatically penalize a doctor who is actually doing incredible proactive therapeutic work by removing a precancerous polyp the moment they find it.
And that leads to a massive concern I have about this entire blueprint. If the data is this messy and patients aren't just neat little predictable numbers on a spreadsheet, won't doctors inevitably get defensive?
What do you mean?
Think about it. If a physician knows their career, their reputation, and their financial rewards are being heavily judged on their proof of service and proof of benefit scores, human nature kicks in.
Ah, see where you're going.
Won't they just start turning away the really sick, complex, elderly patients who are guaranteed to have long recovery times and high costs just to keep their scorecards looking pristine?
This raises an incredibly important question, and it is arguably the most critical human variable in this entire systemic overhaul. The blueprint completely anticipates this defensive behavior.
Oh, it does.
Yes. To combat it, it introduces a mathematical and clinical concept called the frailty risk fingerprint.
Okay, I have to be honest. Frailty risk fingerprint sounds like corporate jargon designed to sound comforting. How can you possibly capture human suffering and complexity in a mathematical formula?
It's a risk adjustment mechanism, and it's essential for fairness. The blueprint acknowledges the undeniable reality that some patients are significantly more vulnerable.
Of course.
A patient with severe heart disease, uncontrolled diabetes, and mobility issues is simply going to cost more to treat, and they'll take longer to heal from a knee replacement than a healthy 40-year-old.
Right.
The fingerprint ensures that when the system compares two facilities or two doctors, it mathematically adjusts the expectations based on the baseline sickness, the acuity of the patient pool.
Okay, that makes sense.
The blueprint explicitly states a core tenet. The fact that sicker patients cost more must never be mistakenly labeled as worse value by the algorithm.
Okay, so it essentially acts as a handicap in a golf tournament. It levels the playing field. So the doctor who willingly takes on the toughest, most complicated cases isn't financially punished for having higher overall costs or slightly lower functional recovery rates.
Exactly. And if we connect this to the bigger picture, this risk adjustment is where health equity becomes a foundational mechanical part of the blueprint.
Health equity, really?
Yes, it isn't just a buzzword or an afterthought added in the diversity training seminar. It is what they call a first-class cut, built directly into the data tracking.
Can you give me an example of how tracking this data organically exposes equity issues?
Let's look at peripheral artery disease, or PAD. It's use case 03. It severely affects blood flow to the limbs. The blueprint tracks the rates of leg revascularization, which are the complex procedures used to restore blood flow and save the leg.
Okay, and what does it compare that against?
It tracks that against the rates of straight leg amputation. By mathematically tracking how often amputations occur without any prior documented attempts to save the limb, the blueprint directly exposes access gaps.
Wow.
Yeah. If the data shows a disproportionately high amputation rate in a specific demographic or a specific zip code, that isn't just a clinical failure. It is a massive flashing siren pointing to health inequity.
Because it proves they aren't getting the right care early on.
Exactly. It proves that vulnerable populations are not getting timely preventative vascular care.
It's tracking the failure of the system to reach the patient before it's too late. I also saw they apply this to maternity care, use case 16, I think.
Yes, maternity is a huge one.
They track the rates of primary C-sections versus the rates of vaginal birth after cesarean, known as VBAC. By comparing those numbers across different demographics, it instantly exposes whether certain mothers are being denied appropriate, evidence-based options for their deliveries based on implicit biases.
Right.
It uses cold, hard surgical data to reveal uncomfortable societal truths.
It forces the healthcare system to look at the human reality behind the CPT code. It holds a mirror up to the institution.
But surely this framework can't solve everything, right? I mean, there's have to be areas of medicine that are simply too complex, too unpredictable, and too uniquely human to be neatly bundled into a 7-part use case. Does the blueprint have the self-awareness to admit its own limitations?
It does, very explicitly, particularly when it addresses breast cancer surgery. That's use case 12.
What does it say about breast cancer?
The blueprint looks at the mastectomy procedure and essentially tells health administrators, stop. Yeah. It warns that attempting to judge the value of breast cancer care by looking solely at the surgical episode of a mastectomy is like trying to judge the entire journey of maternity care by only looking at the 20 minutes of delivery.
Because cancer is a moving target. It's just one sliver of a massive, multi-year journey.
Right. Breast cancer involves timely diagnostic screening, the specific stage of diagnosis, the deeply personal choice of surgical approach, the agonizing decision between immediate versus delayed reconstruction.
Chemotherapy.
Yes, months of chemotherapy, targeted radiation, genetic counseling. The surgery is just one piece of a vastly complex web.
So you can't just bundle it easily.
Exactly. A blueprint clearly warns that trying to jam a systemic disease like breast cancer into a simple procedural bundle will result in a framework that is half-built and deeply flawed. It states that cancer requires a dedicated, much broader condition-level project that goes far beyond a single episode.
That level of self-awareness is actually the most reassuring part of this document to me. It knows exactly where its architectural model works beautifully, like optimizing the clinical arc of a knee replacement or policing the appropriateness of spinal fusions.
Yep.
And it knows exactly where it needs to step back because the complexity of the human body demands a much wider lens.
It's a tool, not a religion.
Yeah.
It's designed to bring rigorous order to chaos, where order is possible, and to deeply respect the complexity of disease where a simple financial bundle just won't cut it. It is a profound shift from merely tracking what happened to measuring what actually matters.
We have covered a tremendous amount of ground today. We've moved from looking at healthcare as a scattered, confusing pile of fee-for-service receipts to seeing it as a unified, logical episode of care.
It's a huge shift.
We've seen how Dr. Opelka's framework uses a rigorous seven-part anatomy to track whether your care was efficient, whether it was safe, and most importantly, whether it actually provided a tangible benefit to your life. And we've explored how it attempts to account for the messy reality of human frailty and systemic inequity.
Absolutely.
And for you listening, this matters profoundly because the next time you interact with the healthcare system, you aren't just a collection of CPT codes and encounter claims waiting to be processed. You are a person living through a clinical arc. Knowing that these blueprints, these bundles, and these hidden metrics exist gives you a powerful new vocabulary. It helps you advocate for yourself, ensuring the care you receive is not just a reflex, but is appropriate, safe, and entirely focused on your actual recovery. So what does this all mean?
I think it leaves us with a truly empowering and maybe slightly radical question to consider.
Let's hear it.
If major health systems, accountable care organizations, and massive health insurance plans are using these exact seven-part blueprints behind the scenes to track the appropriateness and value of your care, what would happen if patients were given these same schematics before they ever agreed to a procedure?
Oh, wow.
Could you use this exact framework to sit down, look your surgeon in the eye, and demand to know your own expected proof of benefit?